بسم الله الرحمن الرحيم. Our next speaker, the father of the neonatology in Saudi Arabia, دكتور عمر بشير، غني عن التعريف، علم على رأسه نور. He's the head of SAB KSA before, and he's the one of the early people who start جمعية الأطفال بالسعودية، وله يعني مساهمات كبيرة جدا جدا نعجز عن ذكرها، ومن أوائل الناس اللي حملوا لواء وهم السودان وأطفال السودان والتدريب في السودان وشغل كل النيوناتولوجي في السودان. الأب والروحي للنيوناتولوجي، كل ما تستعصى علينا حالة بمرجعنا ومصدرنا دكتور عمر بشير، senior neonatologist in all Saudi Arabia. He's the head of the NICU in Security Forces Hospital. درب وكثير وآلاف من الكونسلتن الآن. كثير من الناس أكيد بيكونوا شافوه في السودان يدرس ويدي محاضرات كثيرة جدا على تواصل مع المجلس والسفارة والسينيور كونسلتنت في السودان، عشان همه وشغله الشاغل التدريب والتريننج والتحضير والتدريس في السودان، وربط التريني في السودان بالسعودية، وحتى أنه أنا أعرف ساعي في حاجة زي دي. مهما قلت ما حقدر أوفي حقه، مهما قدمته من هنا إلى بكرة حكون مقصر في حق دكتور عمر بشير. Welcome دكتور عمر بشير. He will talk about respiratory stress in the newborn, or as a differential diagnosis approach to the babies with respiratory stress. Welcome دكتور عمر.
شكرا دكتور أحمد. Can you hear me? Can you hear me?
أيوة واضح دكتور عمر، واضح.
Thank you very much دكتور أحمد. لا يعني طبعا أحمد عايز يكبرني لكن طبعا ما شاء الله على هذول الشباب إن شاء الله اللي بيحملوا الجهد اللي في المستقبل بإذن الله. طيب أنا I'm not going to waste a lot of time. Respiratory distress in the newborn. طبعا it is an important topic, and I don't know طبعا بالنسبة للسودان how can you estimate the incidence بتاعته، لكن definitely worldwide it occurs in 7% of all term babies. Here we need to differentiate between preterm and term. I'm going to concentrate first on the term babies. Term babies, they can develop respiratory distress, and even those late preterm babies, they can also have respiratory distress commoner. It is a cause of admission in 15% of term babies and 29% of late preterm babies to the NICU. And now the causes of respiratory distress are well studied, and from that point on, I think people should always take measures to start prevention and treatment so that we can reduce the burden of the disease. Of course, depending on the cause of the respiratory distress, complications may occur, especially if the cause is not treated. For example, if you have got severe group B streptococcal disease, septicemia, and you are not aware of it, that can end lethally or fatally. Right. All right. These are the risk factors for respiratory distress in the newborn: prematurity, meconium-stained amniotic liquor, cesarean section delivery, maternal diabetes, maternal chorioamnionitis, and of course, prenatal ultrasound findings of structural lung abnormalities or oligohydramnios. طبعا now when we are talking about prenatal ultrasound, now this is a practice. And now our practice is to work in close coordination with the fetal-maternal obstetricians, because they can tell us about any antenatal ultrasound findings. Oligohydramnios is well known to be associated with pulmonary hypoplasia. Diaphragmatic can be diagnosed, and hernia can be diagnosed antenatally. And of course, group B streptococcus can be detected in the mother antenatally, either by high vaginal swab culture or these days by a PCR test, that is polymerase chain reaction tests, which we are now using in our hospital. Now, of course, the signs of respiratory distress, and I think also I'm going to stress on the clinical finding, are tachypnea, nasal flaring, grunting, subcostal and intercostal recession and sternal recession, and cyanosis. These are the 5 signs of respiratory distress. Any presence of these signs that makes you say this is respiratory distress. Then, according to the cause, you will say respiratory distress due to pneumonia, due to hyaline membrane disease or surfactant deficiency. Tachypnea, it is the commonest non-specific finding in respiratory, or metabolic or systemic diseases. And it is a compensatory mechanism for high carbon dioxide and for hypoxemia or respiratory and metabolic acidosis. It occurs in conditions of reduced tidal volume, that is especially to achieve sufficient minute ventilation. So you find a low volume or a small volume lung. So this is the significance of tachypnea. It tells you that there is probably respiratory disease, metabolic disease, or systemic disease. And it tells you that there is probably occurrence of hypercarbia or increased carbon dioxide or hypoxia. And as I said, it occurs with conditions of reduced tidal volume. And these طبعا are mainly probably with respiratory distress syndrome. Now, increased work of breathing, and that is, of course, the baby is having a lot of subcostal recession, working hard to try and breathe. And this is usually results from a mismatched pulmonary mechanism, leading to increased airway resistance and decreased lung compliance. And this طبعا occurs mainly in the preterm babies in respiratory distress syndrome. And when the airway is reduced, the resistance increases 16-fold. That is, if the airway is reduced by 50%, the resistance, the pulmonary resistance or the airway resistance increase 16-fold. Nasal flaring, it is a compensatory mechanism that increases the upper airway diameter and reduces resistance and work of breathing, and retractions occur due to poor compliance and high resistance. Again, clinical findings, the significance of respiratory failure. And this occurs because the newborn cannot sustain the work of breathing. It manifests as cyanosis due to hypoxemia or impaired oxygenation, and impaired ventilation due to respiratory acidosis. Right. The pathogenesis of respiratory distress, there are different factors which can lead to that. Alteration during normal lung development occurring early, as in tracheoesophageal fistula, bronchopulmonary sequestration, and bronchogenic cyst. These are all congenital malformations. In late gestation, the parenchymal lung malformation can also lead to respiratory distress, and this includes the CCM is, of course, you know, now the name has changed. It used to be called cystic adenomatoid malformation. As we said, with oligohydramnios, you get pulmonary hypoplasia. CDH is for congenital diaphragmatic hernia. And as I mentioned earlier, severe oligohydramnios will lead to pulmonary hypoplasia. And this is seen mainly in cases of Potter sequence of Potter syndrome, where there is either renal agenesis in Potter syndrome or polycystic disease, where there is sequence, Potter sequence. Right. So these are things which can occur during lung development and lead to a baby to present with respiratory distress. And of course, these are all inherited, or at least these are congenital. Right. There are complications occurring during prenatal or postnatal transition. These include transient tachypnea of the newborn, respiratory distress syndrome. These are mainly in the preterm, pneumonia, meconium aspiration syndrome, and persistent pulmonary hypertension. Right. What are the possibilities of, or the possible differential diagnosis of a baby who is presenting with signs of respiratory distress? As we said, the signs are tachypnea, nasal flare, grunting, subcostal recession, and cyanosis. Right. The differential diagnosis can be an airway obstruction, pulmonary disorder, that is anything in the lung, of course, cardiovascular disease, especially with congenital heart disease, thoracic deformities and abnormalities, and of course, neuromuscular disorders with hypotonia. They can cause respiratory distress, others. So this is the differential diagnosis of any baby who is presenting with respiratory distress. Of course, if you are dealing with a preterm baby, especially those who are below 32 weeks, then the most likely cause of respiratory distress in that is because of the prematurity, surfactant deficiency, and respiratory distress syndrome. Right. Just to give you some common case scenarios, a term infant born at 38 weeks after elective cesarean section and had oxygen by nasal cannula and having an abnormal chest X-ray. What are the possibilities? Especially after elective sections, most babies might develop signs of respiratory distress. And that is why now it is agreed that you should not do elective cesarean section before 38 weeks of gestation. It should be around 38, 39, or even 40. It is well known that the removal of the lung fluid is important and that is usually what occurs in spontaneous delivery. With cesarean section, that element or factor is not available. So these babies develop mild respiratory distress due to fluid in the lung, and this is what is referred to as transient tachypnea of the newborn. This is because the fluid is not removed from the lung, and this fluid is usually removed by reversal of the chloride and fluid secreting channel in the lungs, epithelium in late gestation. Lung fluid clearance is increased by antenatal steroids, and as I said, fetal thoracic compression during spontaneous delivery with the uterine contraction. And of course, during this stress, adrenaline is liberated from the fetus. How can we prevent transient tachypnea of the newborn? Good control of maternal diabetes. Steroid, I think that is very controversial, although some people have advocated it before elective section. But as I mentioned earlier, the most important thing is to avoid elective cesarean section before 39 weeks of gestation, and to avoid precipitous delivery, fetal distress, and of course, maternal sedation. These are important factors if you want to avoid or to prevent occurrence of transient tachypnea. Transient tachypnea is usually a very mild condition, resolves within few hours or within 24 hours, and usually does not need a lot of interference. Okay, the scenario number 2 is a term baby, spontaneous vaginal delivery. Mother had 24 hours of rupture of membrane. Abgari score was 8 and 8. In the delivery room, they used oxygen, 40% oxygen or FiO2 0.4, but there was tachypnea, and even with the use of CPAP, the baby was not doing well. So intermittent positive pressure ventilation was started. So what is the possibility here? Of course, with this history of prolonged rupture of membrane, the baby is exposed to infection. And the diagnosis would be, in that case, is neonatal pneumonia acquired through the transplacental infection from the infected amniotic fluid in cases of PROM, or if the mother has urinary tract infection, and of course also from prematurity. Very important factor is group B streptococcus colonization of the mother. I know you probably don't have the facility of checking for that before delivery of the baby. We are doing that routinely now, as I said earlier on, either by doing high vaginal swab of the mother antenatally, or now by testing the polymerase chain reaction for group B streptococcus or GBS. And this is very important actually if you are going to prevent GBS. The carriage rate of GBS varies from place to place. In our hospital, when we've done a survey some time ago, we found that more than 40% of our mothers were colonized with group B strep. and group B strep can be carried in the anorectum, in the genital vagina, and it can be carried in the nasopharynx. Of course, the other possibility is nosocomial infection. So this is pneumonia and has to be treated. How do you prevent pneumonia in these babies? As I said, GBS screening has to be done for most of the mothers who the obstetricians are following. This has to be arranged with obstetrician, and that is why these days, I think neonatology is more geared towards the work with the prenatal side, that is with fetal-maternal and with obstetrician. I work more with obstetrician than with pediatrician these days, and it is a very important it is a very important step to improve your management in these babies if you have good obstetric care. So you prevent neonatal pneumonia by screening GBS in the mothers. As I said, you can do it by high vaginal swab culture, or these days now, the PCR test is available and it is quick. And then one of the most important things, if these mothers have any infection or PROM or GBS, then they have to be given intrapartum antibiotic prophylaxis 4 hours before the delivery of the baby, 4 hours. In fact, if a mother is a carrier of GBS and she was given the intrapartum means during labor. If it is given before the delivery of the baby by 4 hours, that will prevent infection in those babies. And then those babies who are at high risk, you have to follow them carefully, observing them carefully. Right. How do you manage those babies with risk factors? Those babies who are symptomatic, you have to do full diagnostic evaluation. That is blood culture. Blood culture is the gold standard of detection of sepsis. Blood culture, you can do the markers like blood count, white cell count, CRP, that is C-reactive protein. And these days, we use more of procalcitonin, which is more sensitive than CRP. CRP is better, is useful if you do it, and then you check after 6 to 12 hours to see if it is rising or not. So full diagnostic evaluation. For early onset sepsis, we don't do lumbar puncture unless the blood culture comes positive. And even you don't need to do the urine. The most important, the blood culture. This is for a symptomatic baby. So have to admit the baby, do the necessary investigation, most important blood culture, and start your antibiotics. There is no, you don't give them time until you get results. No, start antibiotics. And if they need support, you support them with either CPAP or mechanical ventilation. If they need other supportive measures for hypotension and so on, you do that. Asymptomatic babies, only limited evaluation. Can do CBC, blood culture, observe the babies because they're asymptomatic, and don't start antibiotics. So this is for pneumonia. Now, the third scenario is if you have a term baby delivered at 41 weeks by cesarean section because the baby is large, but there was thick meconium during delivery, the baby is limp, cyanotic, with little respiratory effort, Apgar was 217, and the baby had signs of respiratory distress. Saturation of oxygen at 10 to 15 minutes is still 80%. In all babies, by 10 minutes, the saturation, if the baby is okay, should go to above 90%. This baby, until At 15 minutes, the saturation is 80%. And now he's on FiO2 or oxygen concentration of 50%. The baby was started on CPAP, 7 centimeter. The chest X-ray showed infiltrates, hyperinflation. No improvement was seen with CPAP. So the baby was intubated, connected to the ventilator, and inspiratory pressure used was 22 centimeter, which is a little bit high. The oxygen is 60% oxygen is used. Saturation is still low, 80%. The baby was changed to high frequency ventilation, and this baby had an echo which confirmed the presence of persistent pulmonary hypertension. Antibiotics were started. The diagnosis here is meconium aspiration syndrome, and meconium aspiration syndrome is a restrictive disease. Like at the same time, what happens is that the meconium goes to the alveoli and blocks bronchioles, and it creates one-way valve. That is, it distends, but the air doesn't come out. So you get distension, and that will carry the danger of pneumothorax. And this distension, of course, will lead to more hypoxemia and development of persistent pulmonary hypertension. The treatment of meconium, as Dr. Hana was showing earlier on now, is just suctioning. You don't need to intubate them like what have been described before, but still some of them might go ahead and develop severe respiratory distress due to this meconium aspiration. And as you know, meconium also inhibits the surfactant production, so that would add to the problem. So in a baby with meconium aspiration, you've got distended alveoli, you've got surfactant inactivation, and you have persistent pulmonary hypertension if it goes to the worst. Right. So as I said, this was a baby. I've already said that there is chemical pneumonitis, and there is release of cytokines. As I said, it causes partial obstruction with air trapping and hyperaeration. And of course, the result of that would be pneumothorax or air leak. Surfactant is inactivated by meconium and causes more atelectasis with RDS picture. And this profound hypoxemia will be associated with persistent pulmonary hypertension, which sometimes can be very difficult to treat. And how do you prevent meconium aspiration? Is by, if the baby is very depressed and with poor muscle tone and no spontaneous breathing, then you have to intubate. You have to have good obstetric care with good fetal heart monitoring. And in some cases, the obstetricians have been using amnio infusion, although actually it did not reduce the risk of moderate or severe meconium aspiration. As I said earlier, complications of meconium aspiration, the most important is air leak and the persistent pulmonary hypertension. These are the associated with the disorder itself. However, late complications, 50% may develop hyperactive airway disease by age of 6 months, and persistent pulmonary insufficiency may be seen in children up to 8 years of age. Right. Now, of course, respiratory distress syndrome is the disease of prematurity. And nowadays, it is encountered, of course, more in babies who are less than 33, 32 weeks gestation, although it can occur in 34, 35 weeks, or even more than that. And these days, the outcome or the development of RDS, or even, sorry, the treatment of RDS actually starts from the antenatal period. First of all, any preterm, any lady in preterm, especially the one with recurrent abortions or the ones who's having recurrent preterm babies, those babies should have full obstetric evaluation. In centers, they would do cervical length. Short cervix is associated with prematurity. Then to stop the labor, people are using, obstetricians are using progesterone. And as I said, they can use cerclage for cervical shortness. Of course, now there are more and more studies going on the genetic etiology of prematurity. And so far, 6 genes have been discovered associated with the length of gestation and initiation of labor. I'm not going to go into that. Right, so you need to assess those ladies and assess the risk of prematurity. Appropriate maternal transfer to a good perinatal center, and then the use of steroids. Any lady who starts preterm labor, or even before, as I said earlier, if you are following those ladies, obstetrician would start thinking about giving antenatal steroids from week 24 and follow these mothers. When they come in labor, yes, they can be given antenatal steroids, and more important these days, if they are below 32 weeks, is to also to give them magnesium sulfate, which is neuroprotective. Delivery room management of preterm babies. It depends on certain factors. First of all, you have to have a lung protection strategies. And that actually is not only for management of RDS, it also for prevention of bronchopulmonary dysplasia, which is a complication of respiratory distress syndrome. So we have to protect the lung from the damage. We start immediately now with CPAP. And as Dr. Hannah has shown, now we are using the T piece, that is of CPAP. We're not using actually the inflating bags anymore. We're using the T piece, and every room in the living room is supplied with puff with that, and we use CPAP mainly for in these cases. We try not to intubate them, because with intubation, you will start the damage of the lung. However, if you happen to intubate them, you have to give surfactant at the same time. Oxygen, with CPAP, you try to reduce the oxygen as much as possible to the lowest. Of course, in preterm babies, they said you start with 30%. If you can come down to room air, that would be fine. And of course, you try to avoid the lung injury. While in the delivery room, you have to make sure that the temperature of the baby doesn't fall. In other words, avoid hypothermia. And then fluid, if necessary. If you want to, if they are not well, you might need to put an umbilical catheter and give them a volume, give them a volume to improve their perfusion. Antibiotics are given to all babies with respiratory distress syndrome because it resembles the GBS pneumonia. Respiratory distress occurs in 80% of babies below 28 weeks of gestation, and for 90% of babies who are 24 weeks gestation. As Dr. Hana said earlier on, it depends on where you are. Yes, we are now resuscitating babies who are 23 plus weeks gestation, 24 weeks, 25 weeks. We are giving them full support, and the delivery and the resuscitation and the care is attended by a senior person. And the complication of respiratory distress syndrome is bronchopulmonary dysplasia. The problem with respiratory distress syndrome these days is that it is no longer the classical picture of hyaline membrane disease with opacification, airway, bronchogram, and so on. And you might not see them these days because people are using CPAP early and using surfactant early. And we are no longer depending on blood gas analysis. You connect your oximeter and we go by the saturation, keeping the saturation between 90 to 94%. And now with the latest recommendations of the Europeans, the diagnosis is made by assessment of work of breathing and oxygen requirement. In fact, increased work of breathing is an indication to give surfactant. I've already said about the antenatal care, previous preterm birth, short cervix, to use circulage, and for prenatal, pre-labor rupture of the membranes, to use antibiotics, antenatal corticosteroids, and then, as I said, magnesium sulfate is neuroprotective. Obstetricians have been using progesterone, and as I said, there are more studies now towards the prevention of prematurity by the genomics, that is, doing the genetic workup. As I said, 6 genes have been discovered. 3 of them are associated with length of gestation, and 3 are associated with initiation of labor. Already I spoke about delayed cord clamping, CPAP, oxygen, a saturation of oxygen, intubation for apneic babies not responding to positive pressure, and surfactant, and using of plastic bags for the temperature, avoiding hypothermia. Surfactant therapy is only given as rescue. No longer prophylactic surfactant is advocated because it is associated with more morbidity. You give surfactant only as rescue if there is evidence of respiratory distress, or if there is a preterm baby 23 to 25 weeks. It can be used by intubation. Nowadays, they're introducing fine catheters, given through fine catheters put into the trachea with CPAP. That is called the less invasive surfactant. LISA is less invasive surfactant administration. There are special tubes for that. Nebulization, laryngeal mask, I'm not going to talk about that. Surfactant is indicated if a baby is requiring intubation for stabilization. Babies of CPAP of 6 centimeters requiring more than 30% oxygen, and second dose might be required, or third dose if the baby is still requiring high FiO2. The saturation of oxygen targets 90 to 40%. You try not to go above that because it's associated with lung injury, and later on if you carry on retinopathy or prematurity. And keep the alarm limit for your oxygen saturation between 89 to 95%. Non-invasive is preferred to invasive. CPAP for risk of babies of RDS, and all CPAP types of CPAP are the same. Bubble CPAP, BiPAP, CPAP, all of them are the same. And there is no difference between. People say bubble CPAP is better. No, all the studies have shown that there is no difference between them. Synchronized nasal intermittent positive pressure ventilation, that is, if you put CPAP with rate, reduces the extubation failure. And if you can further use high flow nasal cannula, that would avoid more pressure. I think I don't need to go into the ventilation, but in general, if you need to go mechanical ventilation, that is mainly for smaller babies who are less than 28 weeks gestation and who fail to extubation. And we use usually volume targeted ventilation, and the one which you are using is volume guarantee ventilation. High frequency is used especially in air leaks, and we try to extubate as much as possible early. If extubation trial is used, you can do it when you reach a map of 7 to 8 centimeter, or if you are using high frequency, map of 9 to 10 centimeter, or even 12 centimeters. I think I don't want to go, these are more complicated, but anyhow, nowadays in neonatology, we use volume targeted ventilation, which has two forms. Volume guarantee, which is now used by most people. There's another type called volume targeted, pressure limited, and is not is limited only in certain places. Usually the babies spend less time on the ventilator. There are fewer air leaks, and the lung injury or the lung-induced ventilator injury is less with volume targeted ventilation. High frequency, I don't want to go into that. Right. Strategies to shorten mechanical ventilation. You can allow the carbon dioxide to go to as much as 60. Caffeine therapy. Postnatal steroids to be used if the baby cannot be extubated after 2 weeks or so. Relief of pain and sedation. You need to monitor those babies by pulse oximetry, blood gases, temperature control, and so on. And you need to do serum electrolyte and hematological values and start your nutrition with total parenteral nutrition. Hypotension, use of inotropes, nutrition, TPN or enteral, especially breast milk, and monitoring of the electrolyte and blood glucose. I think I already spoke about the genes and so on. I don't think I need to go more. Finally, one important aspect is congenital diaphragmatic hernia. Of course, nowadays we are privileged by the fact that we have very good fetal obstetricians. They would give us the diagnosis of diaphragmatic hernia antenatally, except on those cases who will come in labor and we don't know about them. But now most of our diaphragmatic hernias are diagnosed antenatally, and we provide we plan their management from the time the case is being discussed. We talk to the parents, we tell them about the risk and the prognosis and morbidity and mortality associated with it. We involve the pediatric surgeons early, and we prepare everything, and we usually deliver them by 36, electively either induction or by elective section at 37 weeks as much as possible. And of course, the senior person has to be around to intubate the baby immediately. You don't bag the babies with diaphragmatic hernias, because that will distend the intestines more and they will go up more in the chest. So the management is all should be planned antenatally. And as soon as the baby is delivered, you have to stabilize, intubate, ventilate, and use as much as possible gentle ventilation, so that you use the minimum pressure to give you a good saturation of oxygen. We accept lower saturation of pre-ductal oxygen of around 90 and post-ductal of 75 to 80. That's acceptable for us. And the use of nitric oxide in case there is pulmonary hypertension. They need supportive care. We do not push them for surgery until the baby is stabilized and the oxygen, the inspired oxygen is minimal, the pressure is minimal, and the baby is very stable. So you can go as long as you can to stabilize the baby, 6, 7 days, 8 days. Don't rush for surgery. In fact, those who were where the surgery has been done quickly after birth have more morbidity and more mortality. Now, the plan is to stabilize them in the NICU until they reach a situation where the FiO2 is minimal, the pressure is minimal, and all the other parameters and the vital signs are minimal. And then you send them for surgery. Yeah, I think at this point, I think I've taken my hour and I've finished. Thank you very much. If they have got any questions.
For this interesting talk about respiratory stress, I know it needs one day, not one lecture, but we ناخذ الخلاصة والزبدة والخبرات من دكتور عمر. We have few questions, Dr. Omer, that after which CPAP parameters that I can say failure of CPAP, shift from CPAP to mechanical ventilators.
Okay, as I said, you're using CPAP mainly in the preterm baby. The initial trial of CPAP, which was the COIN trial, اللي بتاعت ناس Kevin Morley, they said they were using CPAP up to 8 or 9. I know if you don't have respiratory therapist and if you are not staying with the baby, a lot of people would be worried to use a CPAP more than 7. So in our unit, we try to go up to 7. If I'm around, yes, I can go up to 8 as long as I'm staying with the baby. But 7 is probably acceptable. And as I said, in the management of respiratory stress syndrome, CPAP 7 and oxygen more than 30% would be an indication for surfactant. Of course, if you are going to give surfactant by endotracheal intubation, probably you will be needing to ventilate that baby. Although if the baby is stable, even if I give surfactant, sometimes I would extubate them and put them back on CPAP because they improve the circulation. But in the tiny babies, especially those who are below 25 weeks, 24, 25 weeks, or even 26 weeks, I think probably those babies will need intubation and and they will need surfactant. And if you're going to intubate them, as I said, you better use volume guarantee ventilation.
Just I want to mention, Dr. Omer, I reached CPAP 9, but that's
you are brave. But you have to be there. Don't leave it.
Yes. And I win now to 7. I win the baby gradually. But starting, I put 9. That chronic lung disease have very bad lung and receive dexamethasone several times and very difficult to wean from the ventilator. The baby self-extubated, so I put on 9.
Yes,
another
question, I agree with you. If you can use 8 or 9, that's what have been used in the COIN trial by اللي اتعملت في استراليا.
عشان الجماعة اللي معانا you have to be careful of pneumothorax. That's what happened in COIN trial. They have 9 patients with pneumothorax.
يعني for the boys يعني في السودان who is going to stay with the baby and watch the baby? This is an important point. When I put the baby on CPAP or intubate the baby on ventilation, I don't go away. I stay with the baby until I make sure that the baby is saturating well, his blood gas, if there is any carbon dioxide retention, is improved, his pH is okay. I don't go away. يعني the problem, okay, and we have taken السبيشاليتي بتاعت النيوناتولوجي بكل المشاكل بتاعتها والمشاق بتاعتها. فلذلك يعني I don't like people, they tell the nursing staff ولا respiratory to put a baby on كده ولا intubate the baby and goes away and just tell them put a pressure of and volume tidal. No, you have to stay with the baby and make sure that he's saturating well and he's stable, blood pressure is okay. And if you're going to use a CPAP of 8 or 9, then if you're going to stay with the baby, I don't mind that.
Okay. Just again, do we need to put early preterm babies on CPAP even if oxygen saturation is maintained?
Pardon?
Do we need to
I think sometimes you're putting it because of the clinical picture, especially the babies who come to you with term babies or near term with transient tachypnea and so on. Giving them pressure would improve their lung compliance, they improve the oxygenation, and they will distend the alveoli quicker. Yani, I think especially with TTN, it is fluid, but sometimes that helps.
You mean not only the oxygen saturation, we have to look for the work of breathing and the general condition of the...
Exactly. In fact, the European consensus on the management of respiratory distress is mentioning very clearly, for example, the indication for surfactant is, and that is the latest one, which was in 21. There was one in 19, and they revised it in 21. That's the European consensus, which is 10 countries, and they recommend to start, to give surfactant if there is increased work of breathing. So they're not depending only on saturation and CPAP. No, if there is increased work of breathing.
What is the better type of ventilation for RDS due to infant of diabetic mother?
Okay. طبعا the infant of diabetic mother, the problem with the surfactant in infant of diabetic mother is the quality of the surfactant, not just the amount or the quantity of surfactant. But they develop RDS like other babies, and sometimes can be very difficult to treat. Nowadays, I think we opt for volume guarantee, that is volume targeted ventilation. We try to go as much as possible away from pressure controlled ventilation. Why? Because when you are using pressure controlled ventilation, and that was evidence, you do not control the tidal volume. So one of the main reasons for babies to develop bronchopulmonary dysplasia and lung injury is the fluctuations of the pressure causes volumetrauma. That is a fluctuation of the tidal volume in pressure controlled ventilation causes volumetrauma. So now the main reason for BPD is not barotrauma only. No, the most important thing is volumetrauma. And for these reasons, people have shifted to volume targeted ventilation, that is volume guarantee. And the good thing about volume guarantee is that you set a volume. You have a set volume according to the requirement. For a baby, you usually, for very small babies, you probably require about 4 to 5 ml per kg. For babies bigger, you probably use about 3 to 3.4 up to 4 ml per kg. And that volume needs to be delivered by the certain pressure. So you stay with the ventilator, see how much pressure is required to deliver that volume. It is important to look at the PIP and the mean airway pressure. And in fact, this is a good way of weaning those babies. When the mean airway pressure in a volume guarantee ventilation drops to about 7 or 8, that tells you that the baby is ready to come out of the ventilator. And so even infant of diabetics, you try to use volume guarantee. I think it would be better for them. Try not to use pressure controlled ventilation as much as you can, except in diaphragmatic hernia, where we talk about gentle ventilation. It is used in diaphragmatic hernia. And طبعا, as I said, and that would avoid the ventilator-induced lung injury, mainly volutrauma in pressure control, barotrauma, and then you have the other factors like atelectotrauma, that is because you need sometimes higher pressure to open the lung, and then biotrauma, which is due to inflammatory markers, and the oxidative injury due to increased superoxide and hydroxyl group. That is why you need to keep your saturation low, and you need to.
I think ventilation, the way of ventilation, weaning and CPAP failure, it needs a separate day with workshop and hands-on work to be more understandable for all people, I think. So at any time, if I know that Dr. Omer Bashir going to Sudan, I will going to announce that, and we can catch him there to give us about ventilation. Again, repeat for us, please, acceptable oxygen saturation in congenital diaphragmatic hernia.
Okay. طيب, I've got a special thing about the oxygen saturation. First of all, طبعا, let us talk about, they might say, not see a lot of diaphragmatic, but talking about the saturation in preterm babies. You know that there have been trials on that. And the last trial was the Canadian trial, or the COT trial. That is Canadian oxygen target trial. And the one before it was a support trial. That is SU for surfactant, PP for positive pressure, O for oxygen target, and trial. The support trial showed that when they were giving oxygen, they had two groups: oxygen saturation accepted at up to 89, and the second group above 90. And they found that with the ones who were given up to 89, except there was more morbidity and mortality. So that when the Canadian did their trial, they came with a saturation of 90 to 94% in the preterm. Why I'm saying that? Because when we started using that, the ophthalmologist came to me and said, you are having more retinopathy or prematurity now. So now in our unit, we're using 88 to 92%. But if you are asking a question, yes, what is the target for oxygen? Yes, the target is 90 to 94, because this is the latest Canadian or COT trial. And you have to go by the evidence which is available. I cannot say this is what I'm practicing now. Like, you have to go by that. For our boys in Sudan, I think they should not aim at higher oxygen. We know that there's a lot of injuries. Now, coming back to diaphragmatic hernia, yes, now we are accepting lower, and this is, in fact, this was a recommendation by the Canadians, recommendation by the latest European consensus of management of diaphragmatic hernia, which would accept actually even 86 to 88, 89 saturation for oxygen in these babies. Anyhow, I would say for post preductal, for preductal, anyhow, I would go for 90%. And for postductal, ولا بالعكس يا أحمد. Probably we're using 75, 80%, accepting that. This is to try to avoid using high pressure, because if you use high pressure, then that might damage the lung more. And this is now people agree that the management of diaphragmatic hernia is gentle ventilation. I know some people are using high frequency oscillatory ventilation, but all the trials have shown that there is no difference between high frequency and gentle ventilation. And of course,
for me, for example, I think that the idea that they think that high frequency is a gentle ventilation, because you are giving a small volume and lower risk to have pneumothoraces and all this. So this is why most people start high frequency in the diaphragmatic hernia.
But there is no evidence that it is better than gentle ventilation. The other thing is there is no evidence that there is a difference between them. Sometimes high frequency, you really need a good setup. Probably I would be okay if I use, and we don't want to go to that, boys, if I use now I'm using high frequency with volume guarantee. It's giving very good results, because with volume guarantee, you are using a very small volume, that is about 1 to 2 ml per kg. But you need experience. You cannot go and leave the baby alone. Most people, they don't know how to use volume guarantee with high frequency.
Yes, I try little 1 or 2 case only. We have some question that what about surfactant in preterm baby? And the other question that to use to start with surfactant or caffeine?
Both. Both. Caffeine, caffeine was used, the trial for caffeine, which was the CAP trial, was mainly, it was for a different reason. But when they did the trial, they found that caffeine improved the respiratory center, improved the stimulation of the respiratory center, improved the contractility of the diaphragm. And in fact, it is a pulmonary dilator. It is probably a diuretic also. And these were 5 things which were found, and hence it was found this way. It was an important factor in prevention or in treatment of bronchopulmonary dysplasia. So now all babies who are less than 33 weeks, I would start them on caffeine, and we start with a loading dose of 20 milligram, followed by a maintenance dose of 10 milligram. And now I use it up to 35 weeks and so, and then stop it. When you stop caffeine, you need to wait for 5 days before you discharge the baby. And so this is for caffeine. All babies, they should receive caffeine.
Really, I face it now. I have extreme preterm who is 25 weeks. Now corrected age, he is 44 weeks, but still needs CPAP as a chronic disease.
Yeah. Oh, this was the problem.
Or you keep to continue.
Yeah, and you better continue caffeine. In fact, the trial on those babies who were sent home without caffeine, they did a trial between the 2 groups. The one group, they gave them oximeters, one group, and the other group were other. But they found that those where the caffeine was stopped, they found that they tend to develop hypoxic episodes at home, which meant that they need caffeine for longer time. You might need caffeine up to 44 weeks post-conception, or in some cases up to 52 weeks. فيعني caffeine is there. Surfactant طبعا indication, any baby who is less than probably 25, 24, 26 weeks, I would give them surfactant. Then Other than that, rescue surfactant if there is an indication, if he's on CPAP, more than 30% oxygen, or has got increased work of breathing. And really.
أعتقد الأسئلة ما حتنتهي والموضوع شيق والموضوع كبير جدا وطويل including the ventilation, the surfactant, caffeine, with the medication. It really it is long. I need a lot of.
I don't know whether it will be really relevant to the MD boys.
Use of steroid in RDS. This I think will be the last question, Dr. Omer, because we have. And my announcement for people who please raise their hands. Please write the question, and we are going to read all the questions.
Okay. Yes.
RDS, steroid in RDS.
Right. Okay. Let's say steroid in preterm babies. The evidence now is that you use dexamethasone. Dexamethasone is the one which is used for bronchopulmonary dysplasia. Usually it is used after 14 days or so, if the baby is still continuing to be on the ventilator. However, now there are people, there was a trial which have used hydrocortisone from day 2 of prematurity and RDS, and 1 milligram per kg per day for 7 days, 0.5 milligram per kg for 3 days, after a total of 10 days. And they found they had good results, but the problem was development of perforation in some of these babies. I think if we, even that, when the trial was done again, I think the perforation was less. So if you are careful, nowadays in the tiny baby, especially below 26 weeks, 25, in our unit, we started using hydrocortisone from day 2 or day 1 for 10 days. So we are using it. The other trial or the other thing which is coming through is the use of budesonide, اللي هو inhaled steroid with surfactant at birth. And there are some reports that it is giving good results if you use surfactant with budesonide at birth. Other steroids have been used like prednisolone and so, but the results are not good. The two which are now used, dexamethasone and hydrocortisone.
Okay. Thank you, Dr. Omer Bashir, for this interesting topic, and I know it needs